Hello everyone. Today we'll be learning about CSF rhinorrhea. CSF means cerebrospinal fluid and rhinorrhea means nasal discharge. So as an ENT aspect, whenever we talk about CSF rhinorrhea, the most important thing that should come into your mind is how the flow is coming from the brain, from the neural aspect into the nasal cavity. So how can this flow even occur? See, we have an anterior cranial fossa, middle cranial fossa and posterior cranial fossa. The CSF from the anterior cranial fossa can come into the nasal cavity via your frontal sinus. Okay. Similarly, from the middle cranial fossa, it can come via the sphenoid sinus or it can come via your EAC. Okay, via your ear. Similarly, from the posterior cranial fossa, it can come from the sphenoid sinus as well as from the ear. So you can see this one. See here. This is the mastoid cells of the middle. Basically, we are talking about the eustachian tube. So the opening in the nasopharynx is basically the opening of the eustachian tube. So that becomes a pathway for your spread of the tumor from I'm sorry, it's not spread of the tumor, it's spread of the CSF. Okay. Particularly, there might be a tympanic perforation, tympanic membrane perforation, and from the eustachian tube, from the opening towards the nasopharynx is the opening. From that opening, it can actually come into the nasal cavity. Okay, so from the anterior cranial fossa, middle cranial fossa, posterior cranial fossa, it can come. CSF rhinorrhea doesn't just mean from the brain; it can actually also come from your inner ear cavity, okay, the labyrinth. For example, there is a destruction of the bony labyrinth, and from that bony labyrinth, the perilymph is being leaking out. Of course, the perilymph is component of your CSF, right? So eventually, it's going to drain into your cerebral aqueduct. So, of course, the content, the thing is same, okay? So it might come from the inner ear aspect, or it might come from the cranial aspect. The thing is almost same. So let's talk about CSF rhinorrhea. So whenever we talk about CSF rhinorrhea, the most important thing that should come into your mind is CSF rhinorrhea may be traumatic. Most of the cases, 90% of the cases, it is traumatic, and 20% of the cases of CSF rhinorrhea is non-traumatic. So whenever we talk about traumatic type of CSF rhinorrhea, the most important thing that should come into your mind is fracture, is trauma. For example, any kind of head and neck injuries, okay, or head and neck surgeries, okay, which has been associated with the break in the cribriform plate of the ethmoid bone that is present on the roof of the nasal cavity, okay. So that break or that breach can actually lead to communication between your cranial vault and the nasal cavity. And of course, we need to also remember about the communication that is persistent in the case of meningocele or meningoencephalocele. For example, there is meningocele, meningoencephalocele, and there is that break in the meninges. And because of that break in the meninges, that fluid can actually leak into the nasal cavity, and the person can come with a complaint of discharge from the nasal sinus when he sniffs it back. When he just sniffs it back, in contrast to allergic rhinitis, in the case of CSF rhinorrhea, it is not going to sniff back. It is not going to sniff back. And a classical feature of CSF rhinorrhea is actually teapot sign, which we actually elicit in a person. That is, when he reclines down or when he just rests his head in pillow, the CSF leaking is very less, or it's minimal, or it's equivalent to no. But when he bows down like this, just turn his head down. When he touches his chin to his chest, the leakage is more, and that is known as teapot sign. So you can see teapot sign in this diagram. The next thing that we see is halo sign. Halo sign is also, it looks like a target sign over here, similar to that of your lesion, tinea lesion. Also looks like this, isn't it? But teneasis, the periphery is erythematous. Here, the center is erythematous. Why is it erythematous? Because of the presence of blood. And the periphery is clear. It's clear because of the presence of CSF, and this is known as halo sign. This is elicited when the patient's secretions is taken into a Wattsman filter paper, or this is elicited when the patient's secretions it drops into the pillow cover. And is it only trauma associated injury? Is it only trauma associated injury? No, it might be non-traumatic. What is the non-traumatic cause of CSF rhinorrhea? It might be a benign intracranial raised pressure. Benign intracranial pressure rise may be there, and that rise in the intracranial pressure is because of various etiologies. That might be because of a tumor, because of hydrocephalus, because of different other etiologies because of which there is an increase in the intracranial pressure. Now let's talk about the traumatic causes. As I already told you about the accidents, which is seen in 80% of cases, okay? Seen in 2% of the head injuries, surgical 20% of the cases, along with endoscopic sinus surgery, surgery for meningocele, transphenoidal hypophysectomy, acoustic neuroma surgeries, any kind of endoscopic surgeries, wherever you just go and just endoscopically ligate endoscopically you go and just you remove the polyp, okay? So this is also a component of your endoscopic sinus surgery. Similarly, that's the transphenoidal hypophysectomy, wherever you have to reach to the pituitary. For example, in the case of craniopharyngioma, you need to go to the pituitary, and you want to access the pituitary via the sphenoid sinus, the stella turcica. So you will actually go from the nasal cavity towards your sphenoid. So that is actually known as transphenoidal hypophysectomy, okay? And acoustic neuroma surgery. And similarly, non-traumatic, I already told you, high intracranial pressure is tumor and hydrocephalus, whereas normal intracranial pressure it can be of strain otitis, osteitis, osteomyelitis, congenital or focal atrophy. Now, as I already explained you this diagram, that from the anterior cranial fossa it can come down, from middle cranial fossa, from the posterior cranial fossa, or from the labyrinth because of any kind of trauma. So what is the presentation or what is the symptoms? The symptoms can be unilateral nasal, watery nasal discharge. Is very sniffed back, it cannot be sniffed back. In contrast to allergic rhinitis. Similarly, it's sweet to taste. Whenever we taste the mucus of allergic rhinitis, it's quite salty. And it increases on bending down and straining, and that is basically a component of your teapot sign. Similarly, it's associated with head injuries, history of head injuries, surgery of the nose and skull base. Headache, and of course I told you that it can be a high CSF pressure. Over here, you can see this one. See, it's a high CSF pressure or low CSF pressure. If it's a high CSF pressure, it's associated with tumor and hydrocephalus, right? So if it's a high CSF pressure, whenever there is a release of this CSF, the person will feel very nice. But in the case of low CSF pressure or normal intracranial pressure, in the case of coughing, strain, osteitis, osteomyelitis, focal atrophy, and idiopathic cases, what can happen is it's relief on reclining or straining. Okay, just reclining, it's okay. Okay, but in the case of high CSF pressure, it's relief on rhinorrhea. Okay, recurrent meningitis can be a case. So a 5-year-old child comes to the department of ENT with certain discharges from the nose. He has a history of road traffic accident, which has actually deformed his facial structures, and a GAR of medicine comes and suspects a case of meningitis. How are you going to approach this case? So this case is CSF rhinorrhea, which has led to meningitis, recurrent meningitis. So for this, of course, you need to give antibiotics to cover organisms causing meningitis. That's moreover a medicine part. So CSF rhinorrhea and allergic rhinitis, head injuries, nasal or skull-based surgeries. So I think this is the most important aspect I want you to take from the slides is the beta transferrin. So this beta transferrin is actually present in the case of CSF rhinorrhea and is not present in the case of allergic rhinitis. And this is a very important aspect when it comes to investigations. The sugar content is more in CSF, okay? It's less in the case of allergic rhinitis. I have already explained this one. Now, reservoir sign, teapot sign, meaning forward produces watery nasal discharge, halo sign, target sign, double ring sign. CSF mixed with blood produces peripheral CSF halo around settled blood on filter paper, below cover. Handkerchief sign, okay, what is the handkerchief sign? Handkerchief sign means whenever you just do a blow in the handkerchief, right? When you just open it up, what happens is that handkerchief is really stiff. It's really stiff. But in the case of CSF rhinorrhea, the handkerchief is not stiff because that's a fluid, okay, that's a CSF fluid. A Of course, in investigation, you have to go for, you need to understand two more important. One is CT cystoscopy, and other one is CSF imaging via fluorescence. So what does that mean? That means you're just going to inject a person that at the level of L1, low port of L1 and L2, you'll just inject a fluorescence, and you will actually see that fluorescence coming out from the nose. Okay. So some fluorescence you can actually visualize it with naked eyes. Some you might need some kind of like fluorescent light illuminations, right? And of course, beta 2 transferrin. So you can look into the glucose level, which is more than 30 milligram percentage. Beta 2 transferrin, CT MRI head and brain with contrast, and CT cystoscopy. Okay, and you can go for intrathecal fluorescence dye injection, DNA under blue light fluorescence, yellow colored CSF. Okay. These are all the pictures that I'm just showing you. See, you can just visualize it, or you can use certain lights to visualize that. This is CT cystoscopy. Now, how are you going to manage the case of CSF rhinorrhoea? It's very easy. Okay, we can go for two managements. One is a conservative management, the other one is surgical management. There's nothing like a medical management. Okay, so we can of course go for a conservative management. So how are we going to go for a conservative management? Okay, understand this point very clearly, that particularly if you are straining a lot, of course there will be leakage. So I want to reduce the straining. Okay, so I can reduce the straining by giving antitussives. Like for cough, maybe dextromethorphan can be given. Okay. Similarly, I would also like to add on one more thing, one more aspect. One more aspect. Suppose you strain a lot for going to the toilet. Okay, when you are at the toilet, you strain a lot. Of course, there will be leakage. There will be a problem. So you're going to give laxatives. It's easy. Okay. Similarly, what can be the other modality of treatment? You're not going to bend down a lot. You're going to raise head like this. These are conservative management. Of course, you're going to give medicines to prevent recurrent meningitis. Now, how are you going to go for? Why are you going to go for surgical management? Failed conservative management, number one. Number two, recurrent meningitis. Number three, there's a problem, livelihood problem, extreme headache because of CSF rhinorrhoea. Okay, so let's look into the things that's written in slides. Okay, now the indications of conservative management is immediate post-traumatic leak within 48 hours. There's a trauma and there's a leak within 48 hours. You need to repair it. Okay, small post-operative slip, small leak, you can leave as it is. Small leak, you can leave as it is. Poor risk of patient for surgeries. So I can't go for surgeries. 80-year-old diabetic female, high diabetic female, who has a fractured neck of the femur also, who has CSF rhinorrhoea also. It's very difficult. Anesthesia is also not suiting to her. We have to go for conservative management. Okay. Next. So bed rest in head-up position, as I already told you. Avoid coughing, sneezing, nose blowing, and straining. Okay. Antitussives for dry, persistent cough. Laxatives for constipation. Medications like acetazolamide, furosemide. Furosemide is a loop diuretic. Acetazolamide, it's of course you're associated with glaucoma medicine also. Of course, it's used, okay, to decrease the CSF pressure. Repeated removal of CSF by repeat lumbar taps for indwelling lumbar subacromial training. So repeated removal of CSF, is it good? Is it good to repeatedly remove CSF? Of course not. Prophylactic antibiotics to prevent meningitis. Major point is the above four and this one. Prophylactic antibiotics. Now, why are we going for surgery? Why surgery? Of course, you know that this was the indication for conservative management. Okay, I can go for surgery. Poor risk patient. Immediate post-traumatic leave. First, post-traumatic leave. Understand this point. Whenever a person has post-traumatic leak, the major management will be, to control all the fractures, control the body. There will be certain hematoma, certain meningeal rupture. hemothorax, hemoperitoneum. You need to control that first. Then only you can go for CSF. Okay. So, what is the indications for surgery? So, indication of surgery is it's a non-traumatic CSF rhinorrhea. Number one, non-traumatic CSF rhinorrhea. Number two, failed conservative management for 2 weeks. Failed conservative management for 2 weeks. Delayed post-traumatic CSF is more than 48 hours after trauma. I already told you, if it was an acute condition, less than 48 hours, leave as it is. But more than 48 hours post-trauma, go for surgery. Okay, failed conservative management for 2 weeks. Okay, it's a non-traumatic CSF rhinorrhea. What about the cause of non-traumatic? It's the tumor, hydrocephalus. That's high CSF pressure. Low CSF pressure, osteitis, idiopathic. Okay, in this condition you have to repair it. Okay, massive post-operative leaks and recurrent leaks. It was leaking. There was a conservative management. It went down. Again, there's leakage. Again, there's leakage. Associated facial fractures. Indications for intracranial exploration: large convex defect with brain herniation, foreign body penetration in the brain, meningitis, pneumocele, refractory to conservative treatment by 1 week. That means a person is having meningitis, recurrent meningitis, not controlled by antibiotics. Antibiotics is given as a part of conservative management, but again he's having meningitis. What to do? Go for surgery. So recurrent meningitis, number one. Number two, it's been more time, more than 48 hours after the trauma. Number three, facial fractures. Number four, failed conservative management. So this you can learn. Next, so what are the surgical approach? So you can go for extracranial and intracranial. So extracranial means, I'll just show you some slides and then we are at the end of the topic. Okay. So extracranial is endoscopic, precisely located site. Single small leak can be intracranial, can also be given large leak for intracranial leak. Okay. So you can give endoscopic repair can be done. Sometimes the turbinate is taken and there's the leakage repair. Okay. Now you can see in this diagram. This is turbinate flap repair, where we are taking the part of the turbinate and we are closing it like a flap. Okay, so there is this temporalis fascia, perichondrium, fat, gel foam or merocell. There's a bone graft. Put intracranial as underlay. Okay, bone graft, fascia, fat, merocell. Clear? Bone graft, temporalis fascia, fat, and gel foam. Okay, great. Turbinate flap repair now. Is this clear? Turbinate flap repair, bone graft, perichondrium, 4-layer endoscopic repair, extracranial, intracranial approaches, extracranial in the case of small leak, intracranial in case of large leak.